This is Types of Migraines, Neurology Edition. So the three types of migraines that were discussed in a previous video were tension headache, migraine headache, and cluster headache. These are your three classic ones that you might have been exposed to in the past. Tension headaches, treatment options include anti-inflammatories and massage. Massage because it actually is involved with a increased blood flow aspect. You could actually hold down your carotid arteries and relieve your tension headache. However, you will pass out. A less severe option is to hold down your a branch of your occipital artery in the back of your head, and that will actually relieve the tension headache. And the tension headache, you can see in this illustration, is that band around the head, and you can actually feel that band kind of dissolve if you hold that occipital artery in the back. Migraine headaches treatments are triptans and CGRP inhibitors, and cluster headaches, oxygen and calcium channel blockers. Migraines are more severe and technically involve sensitivity to light and sound, or photophobia and phonophobia, which is what distinguishes it from a tension headache, although a lot of people will say their migraine headache may come out of a tension headache, or other people will just describe an aura. At least 20% of patients with migraine headaches do have some kind of aura, like a vision change or some indication that their migraine is going to happen. Migraines do tend to happen unilaterally, which is shown in this illustration, and they're primarily in females of reproductive age, whereas cluster headaches tend to be males males in their 20s, essentially. And it tends to be just around the orbital socket, and it can cause tearing and nasal drainage, and typically these patients will end up in the ER because of how bad it is, and you'll put them on oxygen. The calcium channel blocker is more of a preventative. And keep in mind that for treating these migraines, for the longest time, the main thing we understood was that it was a lot of excess blood flow to the head and the peripheral arteries in the head. So triptans help to deal with that. And triptans, even more specifically than calling them vasoconstrictors, they deal with the serotonin dysfunction that happens in migraines. Migraines do also tend to happen in people that have a lot of stress and other mental health issues, because stress leads to excess cortisol, which leads to an imbalance of serotonin, which leads to vasodilation. And triptans, not only are they vasoconstrictors, but they're specifically vasoconstrictors as they relate to serotonin and those 5-HT receptors. So that was what we had for the longest time, and then only in the last 5 years or so did we discover this new protein known as CGRP, and this protein builds up in people with migraines. So we can specifically target this protein with gepants, and if you say CGRP fast enough, it kind of sounds like gepant, gepant. So right now those are just name brand Nurtec and Ubrelvy, and if you were to treat a tension headache with triptans and gepants, it would still probably work, because tension headaches, the pathology of them is very similar to a migraine, and a tension headache can progress to a migraine. And if you treated a cluster headache with triptans and gepants, it would probably also work as well, because they also have that serotonin dysfunction leading to the vasodilation of the peripheral arteries of the occipital region. Not occipital, orbital region. And the gepants actually now are the only approved therapy for the prevention of cluster headaches. We can use, so I put that up there as Emgality rather than calcium channel blockers. We found that calcium channel blockers tend to work to prevent cluster headaches, but really I would use Emgality, and the oxygen would be for the abortive therapy, and Emgality would be for the preventative therapy. And same with the triptans over here for migraine headaches. You would use triptans for abortive, and then you can use CRGP inhibitors for abortive as well, or the monoclonal antibodies as the preventative or prophylactic therapy. And the monoclonal antibodies, of course, are injectables that Pretty much most monoclonal antibody therapies last about a month. Those antibodies can last in your system for about a month. And finally, this is pretty much the main ones that I want you guys to focus on. These 5: tension headache, migraine headache, cluster headache, ice pick headache, and hemicrania continua. With the understanding that tension and migraine headaches are going to comprise about 95% of head pain, and then the rest are going to be less than 1%. So cluster headaches comprise less than 1% of migraine headaches. Ice picks and hemicrania are also less than 1%. Ice pick, as you can see in this illustration, kind of feels like a headache. It will pop up in different spots. So it'll only last for a few seconds, and it'll pop up in the left side of the head, and then it'll go away, and then the right side, and then it'll go away. The treatments for ice pick headaches has historically been anti-inflammatories, specifically COX-2 anti-inflammatories like Elixib and or indomethacin. And then for preventative, gabapentin seems to work best. And for hemicrania continua, this is a type of migraine headache that just literally never goes away. Like most things in medicine, if it's chronic, it's at least 3 months. So this is a migraine that lasts at least 3 months, and then it could be categorized as a hemicrania continua, which responds best to NSAIDs or indomethacin. And the only way to really tell the difference is that timeline in terms of if it's hemicrania or is it a migraine. But hemicrania continua, it can get better and worse. And sometimes you don't really know if they're truly a hemicrania continua or a ebb and flow tension to migraine headache. And the only way to see if it works is to try the indomethacin. And if it responds to indomethacin, then it's like, okay, this is truly hemicrania continua. But usually it's just a migraine. But you can try the indomethacin and see if it works. These are all 12. So there's others to consider that like neuralgias, like occipital neuralgia, trigeminal neuralgia, and then TMJ. I'll just talk about those briefly. Depending on what source you use, they'll say there's 3 types of headaches or there's 10 types of headaches. I've seen some that are as high as 15 types of headaches. I boiled this down to about 12 types of headaches. So there's the 3 main ones at the top, and then the other 2 that you should be familiar with in a neurology outpatient setting. And then there's 6 others to just kind of be aware of, and we will discuss that in the next video.